Welcome and good evening, everyone. I'm Lonnie Friedman, the Health Literacy Specialist at Mackenzie Health Vaughan Library in the Cont'd Vaughan Hospital. Tonight, we have two special guests from Epilepsy York Region. Leslie and Paige will be doing a seminar on epilepsy and seizures. Please place your comments in the chat and I will read them out anonymously at the end of the session for them to answer. This session will be recorded and will appear on Vaughan Public Library's YouTube page in the near future. Before we begin, however, I would like to do a land acknowledgement. On behalf of Vaughan Public Libraries, I would like to respectfully acknowledge that our libraries were built upon the territory and treaty lands of the Mississaugas of the Credit First Nation per the Toronto Purchase Agreement, or Treaty 13. We also recognize we are situated on the traditional territory of the Huron-Wendat and the Haudenosaunee, who have occupied this land before the arrival of European settlers. The city of Vaughan is currently home to many First Nations, Inuit, and Métis people. We acknowledge their contributions to life and prosperity of this land. To introduce our speakers tonight, firstly, we have Leslie Davidson, community outreach and educator, who has been a full-time volunteer for over 10 years with Epilepsy York Region. Via her personal connection with epilepsy through her daughter's experiences as a teenager, Leslie began her involvement with EYR to educate and raise awareness in the community and to be a pillar of support for other parents and families going through similar journey. Paige Jemmett, Director of Social Services, full-time staff for the past 3 years, began as a placement student through Ryerson University. She holds a Bachelor of Social Work. She provides a cornucopia of services, including social programs, referrals, education, advocacy, awareness, and overall support for members and their families and the EYR community. Leslie, Paige, thank you for joining us, and I leave the floor to you.
Thank you, Lonnie. We're glad to be here. For tonight's presentation, we are going to have Leslie start with the first component, and I will jump in later on. As Lonnie mentioned, we're happy to answer any questions that you have, so feel free to put them in the chat. So just to give you a little bit about our presentation, this presentation can be a very useful tool in helping support someone within your community who has an experience of epilepsy. The best information can be gathered from the individual's family, care providers, or doctors, as the team at EYR is not comprised of medical professionals, however, providing you with general information on epilepsy. We want to let everyone know that everyone's experience of epilepsy is unique and individual to each individual and family. And if anyone has any further questions or wants access to additional resources following our presentation, you can reach us at either our email or through the website listed below. I will pass it over to Leslie to get us started.
Thank you, Paige, and thank you, Lonnie. What is epilepsy? Epilepsy is a neurological disease that causes local, specific area of the brain, which is the lobe, and generalized anywhere in the brain seizures. So neurological means that the affected part of the body is the brain. It's common. It's 1 in 100 people in Canada is the ratio. It can develop at any age, something that a lot of people don't realize, that you are not necessarily born with it. You can develop it in childhood. You can develop it in teenagehood, adulthood, or as a senior. In order to have a diagnosis of epilepsy, you must develop it, it must be 2 or more seizures for diagnosis. So if you have one seizure, that doesn't mean that you actually will be sent to a special doctor, a neurologist, to be seen for a diagnosis. They'll wait until you at least have 2. It is not contagious. This is a myth that is believed in some different cultures, because the word disease is used, that it is contagious and that you can catch it. Absolutely, you can't, because the actual the cause and what's happening in for the seizures is happening in the brain, and what you see outside of the brain is the symptoms. We kind of classify it as an invisible disease. And that means that it's, unless you see somebody actually have a seizure, you won't know they have epilepsy. They just look like you and me, and they would have to have that seizure in order for you to know that they have it. There are some genetic connections currently under testing right now for certain types of epilepsy may be genetically found to cause the epilepsy. And in most cases, it's chronic, lifelong, or there's no cure. There is a possibility of having surgery. That's not for everyone. You have to be a candidate for that. It doesn't necessarily mean that you're cured if the seizures stop, but some people do have the surgery and then the seizures do not return. So we can't say that there's actually a cure or surgery is the cure. So that's why we leave it as saying there is no cure. But most people, it will be chronic and lifelong. Most seizures are controlled through medication. About 70% to 75% of people do have control. They may have complete control or they may have a partial control. So they may have less seizures on the medication. And some people do gain full control. And we call it sort of a spectrum disorder because there are many different types of epilepsy. There are different syndromes. So you can have someone that has it very mildly, and you can have somebody that has it very severely or it sort of moderately as well. So that's why we sort of call it a spectrum disorder. So we wanted to let you know the statistics relating to epilepsy, especially if you don't know a lot about it. The World Health Organization has put out that more than 50 million people have epilepsy worldwide. In Canada, we mentioned before, it's common 1 in 100, and about 42 people of any age learn they have epilepsy each day in Canada. In Ontario, we have approximately 90,000 individuals living with epilepsy. In York Region, approximately about 15,000 individuals living with epilepsy. And on average, 1 to 3 children who have special needs such as autism or cerebral palsy, usually it's with another neurological condition, may develop epilepsy, and it usually develops around puberty, but not necessarily. It can happen a little earlier, or it can happen a little later. Our largest newly diagnosed groups are seniors, age 65 and over, and children that are ages 0 to 12. Although, again, as we mentioned before, it can be diagnosed at any age. And as I mentioned before, 1 in 10 people can have one seizure. So you can have one. It's sort of what we call a sort of a fluke of the brain, but they will never have another one in their lifetime. So that is not classified as epilepsy. And what causes epilepsy? So head injuries, infections of the brain such as meningitis, brain tumors, brain development problems before birth, so in utero, strokes generally with the older population that develops it, genetic conditions, and that's usually, we have an example of tuberous sclerosis, which is another neurological condition that is usually linked to have epilepsy occur after they're diagnosed with that condition. Complications with other neurological disorders, as I mentioned, and brain surgeries that may cause the brain to all of a sudden start seizuring because you know, the surgery has caused an effect to the brain. But in approximately 70% of all cases, there is no known cause. Okay, so what is a seizure? So we know that the brain is the control center of our body, and that it's responsible for a lot of the things that we do. So with normal communication, we have millions of cells, brain cells, and that are called neurons, and they are the communicators from the brain to the body. So in normal circumstances, they will, you know, just travel along these pathways, and they will send the appropriate message down to whatever you want to do, whether it's walking, talking, eating, etc. But what happens in a seizure is there's a sudden electrical disturbance that happens along the pathways between the neurons in the brain, and there is an overload of messages because they have sped up, and then what we get are the symptoms that are found in that particular seizure. So this can happen in one lobe of the brain, as we mentioned the word localized. So it can be in one or another of the lobes, but usually it's just the one. And whatever that lobe does is usually has the effect of the symptoms of that particular seizure, or any part of the brain, which means it can happen, the disturbance at the front of the brain the one time, it can happen at the side of the brain another, the back of the brain another. That would be classified as generalized. generalized epilepsy or generalized seizure. And there are many different types of seizures, and approximately around right now the count is about 40, but we are going to touch on 5 of the most prevalent and their characteristics because these are the most common types of seizures. So and I will talk about that. The course of treatment is medication to control the seizures, as I mentioned, regular follow-ups with repeated seizure EEG, electroencephalograms, VNS implant or vagus nerve stimulator. And this is something that's like a pacemaker for the brain. So it's a device that's inserted into the chest wall, and there's a wire that runs up through the vagus nerve. And then it can be controlled that if a seizure is about to happen, the device itself will hopefully stop the seizure, or a person that actually has it can also control it manually. Brain surgery, as we mentioned before, there are limited candidates, but that can be a course of treatment for some. And a referral to a neurologist or an epileptologist. An epileptologist is a person that specializes in epilepsy, whereas a neurologist can treat people with epilepsy, but they don't necessarily work just with epilepsy alone. And cannabis or CBD oil has become, a very popular and effective treatment lately, especially in the last 10 years. The ketogenic diet, which is a sort of like an Atkins diet, high protein, high fat, but low in carb type diet, has had some success with children, and it's now being used with adults. And additional support could be a seizure safety dog, which would be a support for the person that has it, especially those who suffer quite a lot of seizures. A medic alert bracelet is something that we encourage them to wear because it will identify them, especially to first responders if they have epilepsy. At schools, we encourage safety and emergency safety plans, and of course, community support agencies like ourselves that are out there in New York region. And what are the common types of seizures? So there are many different types of seizures we mentioned, but these are the 5 we were speaking about. The first one is called absence, and I'll talk more about that. Or a staring seizure is just an easier term to recognize it by. Atonic, which is a drop seizure. Myoclonic, which is a jerking seizure. So that means that your arm or your leg, like one of your limbs, would be jerking. Tonic-clonic, which used to be called grand mal seizure a long time ago, so it's recognized as that term. And that is a full body convulsive seizure. And the focal seizure, which is the simple or complex partial, which that particular seizure type is the localized, where the rest of them are actually generalized seizures. I would like to also mention that absence used to be known as petit mal, so that might be also a term that somebody might recognize as well. So you can see the pictures along the bottom too, that gives the types as you were looking at that slide. Okay, so we'll start with the local.
Sorry, are you showing us pictures? Because I'm not seeing anything.
Just on the slide here, from the left to right is corresponding with the ways that the
Oh, sorry,
words are listed.
Got you. I wasn't seeing it because I wasn't on that page. Sorry, I was on the
No problem. Let me just explain while you're on. Is because I usually do identify these. I just went a little bit fast there. So the first one would be your absence seizure, the little boy with his hand on his chin. The second one would be an atonic seizure. The third one would be a myoclonic seizure with the man with his arm jerking. The next would be the full tonic-clonic seizure. And the last one would be the focal seizure. And that girl happens to be picking her clothing, which is one of the symptoms of that particular seizure.
Thanks for clarifying that, Leslie.
Yeah, thank you, Paige. Okay, so the localized seizure types is what we'll start out with. So that was the focal, as I mentioned. So as I mentioned just a minute ago, the lady in the picture is picking at her clothing. We have that as a symptom, smacking of lips. They may have a jerk or twitch to their cheek. Or somewhere in their body, but not the myoclonic necessarily. It could just feel like they are having a muscle twitch. They may also wander. That seems to be a very common symptom. And we also have sometimes it's a behavioral thing. So we have clients that will pick up a chair, they will start banging it, and that will be the actual seizure for them. So when it's simple partial, it means they are fully aware during that particular seizure when they're doing the action. When they are doing the like when they would be in complex partial, would be they were unaware of doing that. So they will be doing that for about 1 to 2 minutes, and that is the average time for this particular seizure. So we're talking in a general average time. So we can have people that can have different durations, but this would be what most people would have it for. So you will have those actions, but they're done unaware. So the simple partial, they are aware, and the complex partial, they are not aware. We also have with the simple partial as well, they may have an aura, which is something that will occur prior to the seizure, and that would be something like they may hear a sound in the room that's not there. So for example, a train whistle. They may smell something, burning rubber. They may see something. We have a client that she sort of feels like she's in an orchard, and that seems to be the time that she's having the aura. That's the feeling that she gets. Sometimes we have people that say that they feel a little unwell prior to the seizure, so they might feel a little shaky or something like that. So that's the aura, and that usually occurs mostly in this seizure type. We have had it occur in the next seizure types I'm talking about, but it's most common here. And it is something that's not such a bad thing for some people that have epilepsy, because it sometimes alerts them that they are going to be going into seizure. So they may not go into seizure right away. They may have that aura and it may happen right away. It may happen a little bit later in the day, or it may not even happen at all. If their medication is really holding them, they may only have the aura during that day and they might not have the seizure, but it's something that at least is a sort of pre-warning that they could have a seizure. Okay, and now we'll go on to the generalized seizure type. So the localized one was one in the lobe. This one is occurring anywhere in the brain, and it can be in a different spot at each time. The first one is the atonic, which is a drop seizure. So really what they're doing is they're not dropping very hard. They're usually just losing muscle strength, and they may have their eyelids droop. They may have their heads nod. If they're sitting, they may slump over. If they're standing, they may fall limply to the ground. And they could drop in any position. So they could go forward, they could go sideways, they could go backward. And they usually remain conscious. We do have some that say they feel a bit confused when it's happening, but most will remain conscious. And they last less than about 15 seconds. So it's a very fast seizure. If they fall, that's our main concern with them. And I'll talk about the seizure first aid. There may be an injury, so we look for that just in case they hurt a limb, they hurt their heads, something like that. I should also mention too that not always in these types of seizures are they going to have every symptom. We do have clients that have a few of the symptoms. We have some that have all of those symptoms. The next one is the myoclonic. So it's the jerking of the arm or leg. This usually occurs while they're awake. However, it can be included in our full body tonic-clonic as well, the convulsive seizure. And it is very short in duration, and it's usually not requiring first aid. They're usually mostly bothered by it. They will grab their arm or grab their leg and hopefully ask for it to stop, but the brain is in control and the seizure will occur for that length of time that it's supposed to. So the next one would be the absent seizure. We see this especially a lot in children. We do have adults that have it, but you will have a bigger population of commonality with the children. And what happens is they become unaware. And you will see them look like they're staring like the little boy in the picture. We kind of call it a daydreaming look. You know that they're not daydreaming if you tap them on the shoulder and they don't respond. If you were to tap them on the shoulder and they respond, they obviously are daydreaming. This is a very quick seizure, and it can last between 10 seconds to a minute. And the most commonality, it's about 10 to 30 seconds. And we find that a lot of people with this type of seizure, they miss information. So if you were a teacher, for example, and you said 1 + 1 is 2 and 2 + 2 is 4, they'll hear 1 + 1 is 4. So this is one of those types of seizures where they might be in conversation and all of a sudden stop, and then they won't know when they become aware. They may be confused because you've gone on in conversation, or the information has been, has gone on from where they last heard it. This just becomes a safety, and I'll talk about it before because it is short, but because they become unaware, it does become a safety issue there is one with this particular seizure. The tonic-clonic is the next one we're going to talk about. As I mentioned before, usually called the grand mal long time ago. This is the longer of the seizures that lasts usually between, we've got 1 to 3 minutes, so it can have that duration, but most of people, it's 2 to 3 minutes. And if it goes longer than that, they usually require medical attention. We usually say 5 minutes is usually when someone needs to be called for that. And what will happen, they will lose consciousness and they will suddenly fall, and they usually fall very hard. If they happen to be in a sitting position, they may slump over. And it's called tonic-clonic because the motions are, the tonic is that the muscles stiffen, and the clonic is that the muscles will start jerking. So we have some clients that will be very soft with their movements, and it will be, more of a very light action with that. And we have some that will be jerking very vigorously their arms and legs. They can have the symptoms of shallow breathing, which means they will grunt, and that will be normal and common for them. They just go into a little bit shallower breathing. They may have foaming of the mouth. They may lose your bowel and bladder. And again, as I said, not everyone does, but some do. They can have also drooling. The bleeding from their mouth is generally because they've bitten their tongue, and that's it profusely bleeds anyway, so it's not usually that alarming. And purple or dull lips or bluish and gray skin color, they are not common. We do have some clients that, especially with severe syndromes, that will experience those particular symptoms. So it should be known with the history of the person whether they do that or not, because if it's not known, then definitely medical attention would need to be called. And because this one is 2 to 3 minutes, which doesn't sound like a long time, it actually feels like it when you're watching somebody go through it. They are not aware, they're not in pain, so they don't know that this is happening. So when they wake up, they feel very confused. They may have a headache, and they will be very tired. A lot of our clients will have to sleep, a full, 12 hours after having this, depending on how much action or activity has happened with this particular seizure. So those are the symptoms that you would see with this. Okay, and we do, even though you are on medication, in most cases with this, they still have to watch triggers to seizures because the brain is very sensitive to certain things. So the lack of sleep is a big one. So we like to recommend they get 8 to 10 hours. Missing a meal is not for everybody, but we like them to balance out their meals, make sure they eat every meal during the day. Stress, excitement, or emotional upset, that generally has to be a very extreme, not necessarily just normal stress. And missed or change in medication. So they have to take their medication every day at the same time. So it's really important they don't miss it, because we need to keep the equilibrium balance in the body of the medication in order to keep the brain from having a seizure. The illness or fever is another one. If they're not feeling particularly well, it could be a trigger for them. There is the seizure type called febrile seizures. A lot of people will hear that babies have this, usually children between 0 and age 5. The cause is a fever for them to have this tonic-clonic seizure, and it is a real tonic-clonic seizure. They are experiencing it, that the brain has had that disturbance, but because the fever is the cause of it, it is not considered epilepsy, and they usually outgrow by after the age of 5. Flickering lights like computers, television, cameras, strobe lights at theaters can be a problem for some. Usually 25% of people who have epilepsy will experience that photosensitivity. Hormonal changes for some women, especially, there is a certain syndrome that actually the seizuring will happen during that time of the month for some women. The use of substances, we just always recommend that they are very moderate with their use of alcohol or any drugs, and preferably not to use either or. And weather, temperature, and seasonal changes. So some people can be affected by extreme heat, extreme cold. We do have children in the special needs or adults in special needs that if they have a trigger, it usually or can be this one, which is they seem very sensitive to weather, temperature, and seasonal changes. So usually we watch children and adults with special needs in those particular environments, because that's usually, it usually affects them quite a bit. Okay, and the first aid approaches for different types of seizures. So the first one I'll talk about is absence. It's really safety. So when you have that staring seizure and it happens for 10 to 30 seconds, it can be dangerous on stairs. It can be dangerous for them in water, and it can be dangerous if they're crossing a street or in roadways. So we like to make sure that they are, you know, particularly supported during those times if they have a lot of them. It's really important, especially water, because it doesn't take long to drown in water. And they could be injured on the stairs. So usually we, you know, just make sure that the people around them or, you know, environments that they're in, they're aware of that safety feature or effect. Focal, it's safety only. And that is because they will continually do the same action, and this is more towards the complex partial because they're unaware. Especially if they wander or they are aggressive, we only ask that they be guided away from any dangerous situation and that you use calm language with them. For some reason, if you become a little bit your tone reaches a high level and they can think of it as you're being aggressive to them, they are unaware, but for some reason they respond in an aggressive manner. So that's something we always ask for people to do. The atonic, possible medical attention may be needed, as we mentioned before. This is the drop seizure, so they could have a head or body injury. And myoclonic is only safety. So if they have a limb that twitches, even if they're aware, they just have to be careful on places like roadways and staircases. And tonic-clonic is what we're going to talk about now, and we'll go through that with you. So the first thing is to stay calm. If you've never seen a full convulsive seizure, it can be very, sort of scary. So I always recommend, try to remember that you'll be more help to them if you can remain calm. Certainly understand if you feel, because you're seeing something the body normally doesn't do. These messages, overload of messages, is not really what the person wants to have happen to them. And for you to see it, and you've not seen it before, it can be a little bit unnerving. But it is normal, and it always is normal. Then the person is in any danger. Time, the seizure is really important. We need to know if they're having those average times, like I said in the other ones, 1 to 2 minutes or 2 to 3 minutes or whatever it is. Timing is really important, and we'll tell you why later. Moving dangerous objects. So we just don't want them to get hurt, especially if they have a lot of active action. We just want to make sure that they don't have any more harm happen to them. So if you can prevent that by moving, if they fall under a desk or something like that, or by a chair or wherever it is, that would be the best. To move that. Removing accessories or anything loose around, or loosen anything around their neck. That's really if they have a tight scarf around their neck, or if they have glasses, it's just to prevent further injury. And the scarf around the neck, for example, would be so you can see their airway, and it's not compromising their airway, and it's also for you to get a good view of their airway. Do not put anything in their mouth. This is something we always try to put in, because a long time ago they believed that you could swallow your tongue, so they were putting a stick in somebody's mouth or something like that to keep them from swallowing their tongue. That is actually has been proven not to happen. It's anatomically not would not happen. So we put it in just to remind if you have somebody that's in the older generation to let them know you don't do that. Rolling into a recovery position, we're going to talk about that as well. This is a recovery position that's used with many types of, first responders and everything, but it's very effective for seizures as well. And put something, and I will talk about that, put something supportive under their head. So you see the lady with a pillow under her head. We actually, you could use a rolled up sweater, whatever you have, because they may not be in an environment that actually has a pillow around. But that would certainly help because their head may be moving up and down as well. So we don't want them to, especially on a hard surface, have any more injury. Do not restrain the individual. Sometimes you will think by holding them down that the seizure will stop. That's not going to happen. The brain is in control and that will continue. Do not restrain the individual. Sorry, I said that, sorry, it's restraint. Oh, also, it may hurt you also. If you restrain them, the action may hurt you. Stay with the individual to reassure after the seizure. So we just, because they wake up and they're confused and they will know that they're in a different position than they were before the seizure happened. But it's a very unnerving thing for them because the goal is always to try to control the seizure. So when they have a seizure happen to them again, it's almost like starting over. So we like to make sure that doesn't, that you are calming with them and tell them, you're in good hands and we're looking after you. And we recommend that you do not give the individual food or drinks right after the seizure. And that's because all body processes are affected in this. So digestive tract, respiratory tract, everything, that digestive tract has been, activated, then they may still have the chance of vomiting and so or choking. So we want you to at least maybe hold back for about 30 minutes so that they that system can start settling down. And this is the step-by-step approach to the recovery position. So you'll see, usually this is done when the person's actions have started calming down. So we don't usually try to do this while the movement is high because they're not going to stay in this position and you could also injure them. So once that action goes down, we will have them on their back. Hopefully they have fallen onto their back. That's usually the recommended position for them to be in so that you can keep an eye on their airway and their face so you can see if there's any color change to their face, their lips, anything. So when they're on their back, you can just raise one side or the other, the arm up, as you see in picture 1, and then you will bring the other arm over, and like in picture 2, and that will bring the arm over, and by putting their hand under their chin, will actually keep their face up to you. Then you will go and grab the leg of whatever side you are turning them to, the other side, you bring it over, you will bend it into a sort of a V position, and you will bring it across their body. And then you will bring them right over so that the weight of their body being over will keep them in that position. And they should remain in that position for as long as it is for them to regain full consciousness and are able to talk and walk and everything. And so we usually ask you to keep them in that position for a little bit until they really sound like they're back to normal. Okay, and I'm sorry, we mentioned this before, but we're saying it again, just don't give the individual food or drinks right after the seizure, just highly recommended. We do have some clients that will automatically come out of a seizure and they will say to us, can I have a glass of water? Or I'm feeling hungry. We prefer you don't. And putting them in that recovery position is also one way to drain the fluids because the tongue will go to the side of the mouth, this one. Also, if they have any of the saliva, that will sort of drain from their mouth, even though their mouth will go very tightly. And also if they are going to vomit at any time, once the action stops, then their jaw will relax, they may vomit. So just to be prepared for that. Some people do vomit with every seizure and some people don't. It's just, that's why the history of knowing a little bit about the person is really important, or at least knowing the knowledge that that's a possibility. So post-seizure response, leaving the person in a recovery position is advisable, again, until they're alert. Reassure the individual and check the, again, alertness, make sure the environment is safe and comfortable, and record all details of the seizure before, during, and after. This is really important because it really gives the family As we say, documentation down here, individual, the family, and the doctor, more information. So it doesn't, even if you're somebody that's a stranger, you've seen it happen in a mall, for example, you staying there and supporting that person and being able to tell the first responders whatever you saw is really good information. Of course, if you know the person, always good to give the family that information so they can pass it on. And they can know, because adjustments with medication may need to be made, especially if there's changes to the seizure. So if the time has changed, the symptoms they've had has changed, you know, anything like that, really important. Okay, so the 911 emergency assisted rescue medication, we put this slide in just to let you know that usually we recommend that if a seizure lasts more than 5 minutes, or the individual is experiencing a seizure for the first time, you should call 911. Definitely, if you see that there is any sort of respiratory difficulty, if you see that there's color change, as I mentioned before, definitely to call for 911 as well. And that can be, you don't need to wait 5 minutes on that. If you see any kind of respiratory difficulty whatsoever, then you definitely need to call the 911. Some individuals do have something called a rescue medication, which is administered due to, according to doctor's orders. And hopefully the family will know all about that. And usually if the first responders are called, they'll know what to do about that. But we just like to tell you there is something that they can take, and this rescue medication is sometimes administered during a seizure, and it will bring the duration and the frequency of the seizure down. And that's the hope for that. And that's generally in individuals that tend to have longer seizures. I just mentioned about the decrease of duration and intensity, so I don't need to read that point. Okay, so Paige, I'm going to pass it on to you now to continue with the daily challenges.
Great, thank you, Leslie. So just to talk a little bit more about the social factors of epilepsy and sort of the daily challenges that these individuals are facing, again, might only affect some more than others, depending on if they live independently, they might live with family. Everyone's situation is surely different. Lack of independence is a huge one. So things like holding a job or being able to go to post-secondary education. Social life in terms of social circles like friends and different social gatherings happening. Discrimination and stigma is one of the biggest ones. I know Leslie mentioned at the beginning of our presentation with epilepsy being an invisible disease, and this is what makes it hard for people to really understand what's happening to these people. So during Epilepsy Awareness Month, destigmatizing epilepsy is one of the biggest things that we focus on, because you don't know if somebody has it unless you see that seizure happening. So stigma is definitely a big one, especially if embarrassment can come with it. Some people have very aggressive seizures. They might have it in a community setting with people who they're not familiar with. So this could cause some emotional upset for the individuals as well. Employment and education challenges, as I mentioned, so sometimes withholding employment, having employers being understanding of your condition and putting you in a role that is suitable for a person of their kind, depending on what seizure type they have. Education, like Leslie mentioned, with the absence, if they have a lot of missing information, it can be hard for them to keep up or to handle a full course load. So there can be some factors there. Relationships, not only romantic relationships, but family relationships, there can cause some different factors there. For example, for mothers who have a child with epilepsy, they may have other kids, and that one child may require a lot more of their attention. That can cause some tension between the family, just as an example. Cost of medications, as well as the access to medications and medical support. So for many of you, I'm sure you know that Toronto is where a majority of our accessible hospitals are. However, for those in York Region, that can be a little bit of a trip to access the best level of medical care for epilepsy. So there is a little bit of travel involved. And for many people with epilepsy, they don't drive. So they do rely on others for traveling or public transportation if they're comfortable in doing so. With anti-epileptic medication as well, sometimes the cost won't be covered through OHIP or medical plans, depending on the generic or name brand. So this is something that people have to take into consideration too, because sometimes one may not be as effective as the other, and therefore cost can come with that as well. For those that live with epilepsy, these are some of the common things that we hear from them in terms of the way that they feel about it. So they might feel isolation. So both for the individual living with epilepsy, maybe others aren't understanding or they don't feel comfortable going out based on their seizure frequency or control that they have. And in other situations, it can be for parents too, who are afraid to take their children out, or maybe other parents and mothers and family members aren't understanding what their direct family circle is going through. So isolation is surely a big one. The feeling of being different or excluded, primarily in school-age children, it can be very hard to overcome and accept having epilepsy and managing that, never mind dealing with the bullying or different things that can come with that at school. And then the feeling of fear, anxiousness, and nervousness, like I mentioned, going out in public settings, taking public transportation, even just sometimes working in a public setting can be very nervous for people who know that they don't have full control over their seizures. So this is a few of the most common feelings that we have expressed by our members. So some of the ways that you can do to help or be an ally for these individuals is to not be afraid. As Leslie mentioned, it can be very overwhelming to see somebody have a seizure for the first time, no matter what type of seizure. So to try not to be afraid and understand what's happening, understanding what they're going through, not only with the seizure, but everything that comes along with it. They might be missing school, they might be missing work, they might have extra time away to take care of themselves. Being a friend, so of course, being there for them, offering help, ways in which you can support them outside of that relationship, and being supportive, offering maybe for a drive or for young kids, sometimes they have a school buddy that'll bring their homework home for them. So just different ways that you can definitely help these individuals. The next thing that we wanted to talk about is what is Purple Day. So I'm sure as all of you can notice, Leslie and I are both in our purple shirts this evening. So purple is epilepsy's color. And just to talk about what Purple Day actually is, it's a movement that was started by this young girl here down on the bottom of the right screen. She's not so young anymore, but at 9 years old, Cassidy Megan from Nova Scotia began Purple Day because she wanted to create awareness for those living with epilepsy to have a further understanding. Her dreams of her having her story heard actually turned into a recognized global movement. So now March 26th every year is celebrated as Purple Day across Canada. The month of March is known as Epilepsy Awareness Month as well. So not only on March 26th do we celebrate Purple Day, but all March long we celebrate March awareness. This is just to help, again, spread epilepsy awareness, get education out in the community, and for more people to be aware that it's much more common than they think. As Leslie mentioned, 1 in 100 is much more common than people expect it to be. And during this month, we obviously encourage everyone to wear purple. So whether that's a shirt, an accessory item, posting on their social media and taking part of the campaigns that happen. And there is a Purple Day website for those interested in learning a little bit more about it. And just to talk about what our agency does, so our main thing is for advocating, supporting, educating, and promoting awareness around epilepsy and for those living with epilepsy, whether individuals or families. Right now, some of our social support programs that we have running is our Adult Advocacy Alliance, our Parents for the Power of Purple. We have a Purple Pages book club that runs once a month for those that enjoy reading. Children and Family Community Club. So we have different events for children, their siblings, and their parents throughout the months. And we now have our Glimmer of Hope Summer Camp that we're running for our second year this summer with 20 kids across York Region living with epilepsy. We do obviously adjust our programs based on the community needs. And we do have a lot of more private individual options that are available through Cont'd. And then just like today, how we're out here educating within the community, we're happy to come out to any community-based learning environment, workplace, or sessions to educate both employers or in fellow coworkers for individuals living with epilepsy that are working full-time or part-time. And school-based education is one of our biggest ones. So September through June, we are very busy getting into the schools to get that information to teachers, EAs, and all of those support staffs. And we also do classroom educations too for young kids to have an early understanding of what epilepsy is. We do a bunch of fundraising initiatives and community outreach events as well. So like I mentioned, with March being Epilepsy Awareness, that is certainly a big month for us. And we're always open to volunteer opportunities for individuals in our community. I know many students look for community service hours during high school, so we're always happy for any extra hands to help us throughout these events and create those funds to continue running programs like these. On this page here, we've just added our contact information. So again, we have our general email and website listed. However, if you'd like to reach out to either Leslie or I directly, our emails are on there, or you can again find them on our website. We are currently located in Stouffville. However, we do cover all of York Region. And if by chance you're on the border and not sure where to reach out, we'd be happy to redirect you or support you anyway. So at this point, we do want to thank you all for coming out and joining us this evening for this session. Simply by being here and getting educated on epilepsy, you have made a difference to those living with epilepsy within your community. And we will move on to questions at this point.
That's great. Thanks, Leslie and Paige. Very informative, and you both did a great job of demystifying seizures and epilepsy. So for those who've joined us, you can either unmute yourself and ask a question to Leslie or Paige, or you can type it in the chat.
Lonnie, do you want me to close the screen share for this?
Sure. Okay, I could see. Is it Rose?
Yeah.
Go ahead with your question.
Well, two questions. One, is it realistic when your child, in the case of my child, being treated for epilepsy, is a realistic treatment goal to say 0 seizures? Because I guess we went back and forth a lot with the idea of how much medication, you know, was maybe too much, and she was having them months apart. So it became a question that the side effects were a lot. And what was the goal? What was the treatment goal? Were we trying to get to 0? Is that a realistic treatment goal? And I guess the other thing was just to see if I could get in touch about one of those social groups. But I guess you've had the contact information up, so I have that.
Great question. I'll take that, Paige. I would like to say that the ideal goal is to get to 0 with the seizures. That's the ideal goal for the doctor. The realistic goal is to bring the number of seizures down, the frequency down, the duration down. So I think I would, to answer that, say that's the realistic. But the ideal, the first thing they want when they diagnose is that we're going for the goal of trying to get the seizures completely under control. But as we mentioned, that because it's a unique experience to everyone, the commonality is the seizures, but not necessarily the experience is the same. You really have to hope you get that ideal, but you have to go with the realization that we're really trying to make the quality of life better. So to make sure that there's less seizures happening, and hopefully, fingers crossed, it will just get better and better and better. It takes a long time to get control for many individuals. My own daughter, it took 6 years to get a control of the seizures at all. So it's not, you know, something that happens right away. So it may take time. You may get eventually to that goal, but it will not necessarily be right away.
Okay. Is it true that the brain learns? Like, I think I was also told that if you allow the seizures to keep happening, they'll happen more often. So can the brain actually get into a pattern?
It is a possibility. The brain is a mysterious part of the body. We have had people that have been seizure-free for a long time. They go off their medication, and then all of a sudden the brain remembers at one point. Even if I have a client that was 30 years without seizures, and they went off medication because the doctor felt that it was enough time to be off the medication, and the person had a seizure within the first week. So once that happened, the brain started seizuring again more frequently. That, I'm going to say, I want to clarify, that's not 100% with everybody, but
Right.
it is a possibility. We also have Sometimes if some surgery is done on the brain reads the scar tissue as a problem with the communication. So that's why somebody might start seizuring after surgery, because the brain is now reading that scar tissue as something that is disturbing the neurons' communication. So things can happen with that. And usually that is again, so many things can affect it. Even body changes can affect it. So you can have somebody that can have a control of seizures, even on medication. Maybe they developed it in their teenagehood and they were great for their 20s and 30s. And then once, for example, women with the hormonal changes that happen in their 40s and 50s, that could reactivate the brain to see it as a problem, and it will be sensitive to that. And that could change their seizure activity from being completely controlled to starting again. Very good questions.
That was very interesting. Thank you.
Yeah, you're welcome.
And Rose, in terms of the social programmings, if you do just Google our agency and come across the website, our direct contacts are listed there. I'd be happy to connect with you.
Okay.
And that way, if you have more specific questions as well related to your child, Leslie and I always set up private meetings with clients too. So we'd be happy to meet with you individually if that's something of interest for you.
Yeah, I didn't know if you had a support group or.
Yeah, we have a parent support group. Our kids have a chance to meet others through our social programming events, but we do also offer those private meetings for those who have questions or maybe need some support in school or work, whatever that might look like for your situation.
Okay, perfect. Thank you. Thank you.
No problem.
Thank you for your question.
Thank you.
That was great. Is there any more questions? Again, you can leave it in the chat or unmute yourself.
What about febrile seizures? Do you see kids with febrile seizures eventually growing out of it?
Very good question. I'll take that, Paige. The febrile seizures usually are an outgrow. They usually will not have seizures after usually the age of 5. We have had some that they continue after the age of 5, very not common, but if they do continue after the age of 5, it may lead to a diagnosis of epilepsy going forward. It's very possible for that to happen. Again, very uncommon, as most will subside by the age of 5, but I just can't tell you that that would be for absolutely everybody. They may experience the seizure with the fever when they're 6, 7, 8, then they may not show any seizure activity, and then as a young adult, later in their teens, a young adult, all of a sudden they may have a seizure out of the blue again. And then it will start up. And then what will happen is the doctor has tracked it that those febrile seizures were not the normal febrile seizures of somebody that will outgrow. It's unfortunate that the brain probably did those febrile seizures then with the effect of a fever, but then it's changed. The brain has recognized and become sensitive as they've gotten older. But again, not common.
I just added into the chat there as well, Leslie and I's email for anyone who's looking to connect with either of us directly after tonight's session. So you can just copy and paste that before we've exited.
Is it because, so thank you, Leslie, for answering, but is it the child having seizures later on? Is it possible that the threshold is what's the word again, is lower, so therefore their risk of having seizures increase?
Actually, that is a very good question, and thank you very much. Well, it's actually sort of a question and a comment. Thank you for bringing that up. There is sort of research that shows that there are you're born with a certain threshold. That's correct, Cher, that you're born with a certain threshold. And some people are born with lower thresholds than others. So if you are born with a lower threshold, and you're not able to tell until they have a seizure whether they may be that person that develops. So people that develop epilepsy are likely born with a lower threshold to seizure, so a higher sensitivity to the brain to seizure. And so if you had a moderate threshold, the likelihood is you could go either way. If you have a very high threshold, then you will never have a seizure in your lifetime. So children that have febrile seizures not necessarily do not have a low threshold. That again, as I said, it's not considered epilepsy. It's just the brain reacts to a fever at that age, and it's usually due to the development of the brain, because the kids' brains are still developing up until up until age 5 is a really crucial time. But if they do have a particularly low threshold as well, and they have had febrile seizures, there is every chance, there's a good possibility they could be that person that does develop epilepsy later in life. So that is a very good comment, very good point. I used to talk about that quite a bit. However, I had people that were really confused because they kept saying, well, how do we know we can test our children for thresholds and everything? That's not something that can be tested. It's something that's only found out once the seizure activity happens. So I kind of removed it until I got a brilliant question like yours. And and I love to explain it to you that way. I just, we don't stick it in the general because it causes a little bit too much confusion, because then people start thinking, well, is there a genetic thing we can get tested for that and everything? And that's not a possibility. It's just the threshold was brought in as research because they found that the people who were developing epilepsy, they seem to have a more sensitive brain to anything happening with the communication with the pathways. So very great question, Cher. Thank you.
Okay, one last call for any remaining questions. As one of our participants said, they really appreciated the presentation. It was quite informative.
Thank you. Thank you. I'm glad you found it informative.
Great. Okay, I think we'll call it a night then, everyone. Thanks again for joining. For more information, you can contact, again, Paige and Leslie. You can Google Epilepsy York Region. Actually, better yet, I will send all the people who I sent the Zoom link earlier today, I'll send you their website, the link there. So check your emails for that as well. Okay.
That's great, Lonnie. Thank you very much for having us tonight. We're pleased to come into the Vaughan Public Library connected to Vaughan Court-Lucci, and we're happy to come back in the future again.
Yes, thank you. Thank you for having
Absolutely.
me. Thank you for joining us.
Thank you. Very informative presentation. Thank you.
Thank you, Cher. Thank you for joining us. Thank you, Rose.
Thank you. It was nice meeting you both.
Bye.
Okay,
Good
take
evening.
care.